Okay. Good morning. I'm Robert Dempsey, and on behalf of the Foundation for International Education Neurological Surgery, or FIENS, I want to welcome you to our virtual visiting professor program. As many of you know, FIENS has been dedicated for over 70 years to the education of neurosurgeons worldwide. This is founding programs where there are none, supporting programs. We are now the largest purveyor of fellowships for international education in neurological surgery. And a big part of that is our continuing education programs, where our fellows go on to become our faculty and our volunteers in education. As one teaches the other, another teach on. We're so very happy as part of our virtual visiting professor program to have some of the real luminaries of neurosurgery participate because they understand the importance of your education. And today we're very, very lucky to have Dr. Misra join us. He's one of the giants of global neurosurgery in many, many ways. An outstanding surgeon, especially in the skull base, as he will talk about today, but also in the administration of global neurosurgery, the education programs, where he's been very active at every level. It's quite an honor to have him here. And as always, we will have the program moderated and introduced by one of our former fellows. Dr. Getachew is now going to join us and introduce our guest. Dr. Getachew.
All right. Hello, everyone. Thank you, Professor Dempsey, for the very kind introduction. I'm Dr. Getachew, a neurosurgeon from Ethiopia. I'm last year's FIENS Fellowship graduate from 2025. That was from the FIENS Community for Neurosurgery Initiative program, which is part of the FIENS, one of the multiple FIENS fellowship programs. And I would like to take the opportunity to mention a name here, Dr. Shamsafabi, for hosting me and for the valuable experience he has given me during my stay, for shaping my experience in my professional development. All together with the FINS board members and everyone who contributed for bringing that fellowship program into happening. Really, I'm a living example for your program is working. You're a great deal of impact in across the world. It's an experience for life for the physicians and patients out there in the world. Keep up the good job. I'm the direct beneficiary of that, and I would like to thank everybody for that. Today, I feel honored moderating this professor virtual visiting on behalf of FINS. Our topic will be on the current strategies in the treatment of vestibular schwannoma, and this will be presented by the very based in the prestige neurosurgeon, Professor Basant Misra. He is the chairman of the Department of Surgery, head of neurosurgery and gamma knife radiosurgery in Hindujab Hospital and Medical Research Center in Mumbai, India. And he's when I was doing my little research, his contribution is actually filled of the term first, repetitively mentioned it. The first to introduce the gamma knife surgery for the whole Southern Asia, and he's the first to start the like image guided aneurysmal microsurgery, and he introduced also the airway craniotomy into India for the first time. And among other advanced skull base, vascular, and micro neurosurgeries he's done in life. And he's been in leadership roles. He's been the one of the senior leaders as the first vice president in the WFNS, also the head of the Neurological Society in India, also the Neurological Society in Asia, and an Australasian Neurosurgical Society. And his achievements and contributions didn't pass unrecognized. He has had honorable awards. He received the BC Roy National Treasure Award from the President of India by himself, and he also received the Lifetime Achievement Award from ANS in 2025. So I feel honored and welcoming him today to speak about the very best of his job, vestibular schwannoma. Everybody, please help me welcoming Professor Basant Misra. Professor Misra, the floor is open for you now.
Thank you. Thank you, Dr. Getchio, for a very kind introduction. Good morning, Professor Dempsey, Professor Rock, and the FIENS for inviting me. It's indeed a privilege and honor to be here, and I hope I can contribute to the FIENS programs by this talk. So without wasting time, let me start with my talk. Let me share if it works. Just can you tell me if you are seeing my slide? Yeah, that's good.
Yes.
All right. And you are listening to me okay? My voice is fine?
Yes, sir.
Thank you. Thank you. Right. So today's talk would be management of vestibular schwannoma, contemporary strategies. So there is a lot of debates, a lot of controversies. This will be from my side, the way I do it, and my views, and with some literature. Okay, for this presentation, I would be presenting the microsurgical techniques I use, and some of the safe surgical tips for the young neurosurgeon out there, and the various treatment strategy for vestibular schwannoma. As we know, the microsurgery, radiosurgery, and observation, and what I think about the various modalities of management, my personal recommendation, and the bottom line. So I have a long-standing interest, and this is a historical patient actually when I was in UK training. This is the first patient in 1986, which I could preserve both the hearing and the face. So that was some kind of stimulation for me. And this was 1993, the first 100 consecutive cases which I did, which we published. If you see there, the very high total excision rate, though seventh nerve preservation not so good. We have moved on a little bit. I'll tell you how. This is my current experience. This is one of my residents analyzed. This is the number of patients I have operated, the number of patients gamma knifed by me. Many of these patients have been operated by another neurosurgeon, and I have done the gamma knife part. Of my patients which have been operated by me, 19% of these patients have gone on to get gamma knife radiosurgery in their follow-up period for residual or recurrent tumor. Now, all my cases of vestibular schwannoma, when I do microsurgery, it is by retrosig approach. We all know the various approaches. I'm not going to that literature because you can get it in the books. I recommend that retrosigmoid to be done because I think all sizes of tumor are possible to be removed by this. Hearing preservation is possible. There's a very small bone anchoring at the intra-auditory canal and meatus. So I don't think there is extensive skull-base approach or middle fossa approach, which are limited for indications which have, for example, the middle fossa, very small tumors, translab approach, somebody who is already deaf. So this is something which can serve all types of tumor. So doing one type of surgery all the time, you get better. So I would recommend that the young neurosurgeon to specialize in one type of surgery. Some examples, this is an intracanalicular tumor. Very rarely we do it now. This is about 25 years back, one of these patients. And you can do it this retrosig approach, dissecting out from the cranial nerve 7 and 8, and the nerves are intact, the tumor is out. And this just to show that this is a little bigger, who's 2, and most of my patients and the lateral part of the tumor, when we're trying to preserve hearing, we use the endoscope assistant to take out the lateral part of the tumor so that we do not damage the labyrinth. Now, the point I want to emphasize in this slide is when the tumor is small, CUS 1, 2, or 3 sometimes, the nerve looks much better. The anatomical configuration, the functional preservation is much, much better. The giant tumors is a little more difficult to have that kind of thing. Now, this just want to emphasize on the arachnoid planes. If the arachnoid is covering the lower canine nerves, whatever the arachnoid is covering, leave it alone. That's the best cover for the normal anatomy. So we do not distort it. The blood doesn't go into the subarachnoid space. The risk of the hydrocephalus, risk of postoperative headache, spasm, all that is reduced. So it's better to leave the arachnoid intact wherever it is possible. CUS 3, again, same retrosig approach. We do a craniotomy now. The first thing we do is release the CSF, the cerebellum become lax. We do a linear incision of the dura. We don't do the side cuts, which has been emphasized in some of the older textbooks. What it helps is you have a watertight closure. You can do a watertight closure. When you do the side cuts, then the watertight closure is a little more difficult. And CSF leak is one of the major problems of skull-base surgery. Now, I will go a little fast forward just to show you the quality of now we do the drilling of the intra-auditory canal. The important thing about this is why drilling. You do 180 degrees, something which has been emphasized by Dr. Fukushima many years back. What it does, it helps to, kind of dissect in the intra-auditory canal with a lot of space, and you're not cramped for safe space, and so you do not damage the cranial nerve 7th and 8th because of lack of space. And this is a stimulator dissector we use for dissecting, and this is a hook. And now you can see the quality of nerves you see when the tumor is not very big or giant tumors. And this is my suction, which is a calibrated suction, which I often use for dissection of the tumor. This is on the brainstem side, and there's a patty between the tumor and my instrument so that I do not damage accidentally the neurostructures. And then again, this is without any suction. This is a calibrated zero suction, and I'm dissecting out the tumor from medial to lateral, take out the last bit of the tumor, most part which is most stuck to the nerves is just medial, as we know, just medial to the interauditory meatus. And we're checking the nerves, the function. This is the facial nerve, cartouche facial nerve stimulator. We check, and with a very low 0.2, if you are getting it, that's a very good function at the end of the surgery. So what's happened, this is a girl actually, I think this is an Iranian girl who came to surgery with us, and you can see and we fix, currently we fix the bone with a plate, and this is supposed to reduce the post-operative headache. And this is the patient. Grade 1 facial function normal, hearing good good hearing. This can be achieved in tumors which are not very big or giant. So in microsurgery, is total excision possible? Yes. IS drilling is almost routine in my practice, but total excision is not always possible. Sometimes we have to leave a little bit of tumor because our complete focus today is function preservation. So we would not mind leaving a thin sliver of the tumor attached to the nerves or critical structure, brainstem or a vessel, if you have to preserve function. Hearing preservation is possible, as I showed you, but unpredictable, at least in my practice. Monitoring in all cases is mandatory, and this should be the standard of care. I'll give you some safe surgical tips, which I find useful during positioning. These are two ways of, I know in the United States, most patients are operated vestibular schwannoma in a lateral position. That's what we do today. But the FIENS group and many European centers are doing the FIENS position. Critical to see that the foot is above the neck, so they reduce the risk of venous embolism, and all the pressure points are padded. And we have TEE, transesophageal echo, is very critical because you pick up air embolism, which is very common, may not be clinically significant, but it's not uncommon to have air embolism. We also prepare the thigh for a fat graft if necessary, and so it is important to be prepared for that. Now, semi-sitting position is an advantage. It's a lax brain, and you don't have to do an extensive C1, taking it out, foramen magnum, often not necessary. There is very minimum, no coagulation, blood drains away. And you have an advantage of two-hand dissection. The surgery is much faster, and claim that there is a better preservation, at least the SAMIS group. I'm not so sure about it. Disadvantages, we all know about the air embolism, elderly and cardiac dysfunction. Patent foramen oval is a relative contraindication, though some groups, the German group, some of the groups, they still do it. And the need of retractor is there because the cerebellum falls down because of gravity. Though you don't have to retract, you have to support the cerebellum. And I think it's very important that you have the transesophageal echo if you are doing semi-sitting, so that you catch the air embolism early to produce to reduce the risk of damage. Now, prevention, as I said, feet above the neck to reduce the risk of air embolism. you have a central vein access. And in all of those tumor surgery, we have a positive end expiratory pressure, unlike all of the tumor surgery in the recumbent position. I told you transesophageal echo, and at the end of the surgery, we increase the venous pressure to see if there is venous bleeding, because in the semi-sitting position, the veins get collapsed, and you can come up post-op with a hematoma. Now, if there is a air embolism, which is not uncommon, the anesthetist have to be prepared to compress neck veins, and the another anesthetist should be aspirating air from a central vein access. Now, one thing which is not so emphasized in the literature is the risk of hypotension in a semi-sitting position. I'll just give you an example. This a lady, she was from Bangladesh, who was a 3.5 centimeter tumor. We removed the tumor, a complete excision, and when we woke up, the patient woke up with a paraplegia. Then we took the patient for MRI. You can see the diffusion restriction there, and this patient had ischemia in the dorsal cord, and because of a very transient blood pressure drop. And when we analyzed all the case, there was a very transient drop of blood pressure systolic below 90. And so one has to be very, very careful that we do not, you do not have this low blood pressure. Fortunately, the patient improved because of ischemia and it was not infarct. But you can understand the stress both the patient and the surgeon going through when you have not anticipated this problem. So this was the way I used to do it. But now most of my vestibular schwannomas are operated in lateral position because the risk of this semi-sitting position is something which is not under my control completely. This is under anesthetist control. So I would rather not have it. Now, during craniotomy, avoid injury to the sinus and avoid injury to the vertebral artery. Now, to avoid injuring the sinus, though we do a craniotomy here, over the sinus, we drill it. And the key to know where the sinus is about 2 to 3 millimeter on the first emissary vein. Lateral to that is the sinus position. That's the anatomical landmark. You can get it. So you drill that part and do not use the craniotomy to prevent laceration of the sinus. Now, when we put the position in the patient position, the head is rotated. So the vertebral artery becomes more medial. So if you have to operate, especially in lateral position, when sometimes we have to take off the foramen magnum, and sometimes very big, huge tumors, which we see in my country, you have to take off the C1 posterior arch one side. Then we go to the middle and then subperiosteally retract. So the risk of damaging or injuring the vertebral artery goes down. Now, during tumor removal, now these are giant tumors. These are very common things which we see, a large solid cystic tumor. Now, this is one of my residents has edited this. So this is this is a lateral position. This is the position I want to just go through that. This is how we do it. So this is mastoid tip, 2 fingers below. And this is the line joining from the zygomatic arch to the onion. If you draw a line, that's above that line is the transverse sinus. Now we are operating a giant tumor in a semi-sitting position, then it's very good. When you're operating in the lateral position, the brain bulges. And even if you try to do the CSF drain from the cerebellomedullary system, it's sometimes very, very difficult. So we take off the foramen magnum, we drain the CSF below the foramen magnum from the spinal canal, and then the brain becomes lax. This is a cystic solid tumor. So we decompress the cyst. Once we have decompressed, the cerebellum lax, and the surgery goes on as before. Now, even in large tumor, giant tumors, we can still preserve the facial function, though hearing preservation is not possible many times, and most of the time they are deaf. Now, I just want to show this one, which some things which we have realized is very, very important, is packing the auditory canal when we are drilling it, because that could be air cells in auditory canal, and that could be paradoxical CSF rhinorrhea. The other things which we have found, which have reduced the CSF leak, both pseudomeningocele and leak from the mastoid air cells, is putting fat on the suture line. We do a direct suture of the dura. This is linear incision, and we suture a layer of fat, which we take from the thigh, over the suture line and stitch it. And we put some fat on the mastoid air cells if that are opened. This has reduced significantly our CSF leak, pseudomeningocele, CSF rhinorrhea, and so on. And you can see even in this giant tumor, the patient had a good facial function. Now, monitoring in many places with resource constraint, the monitoring, they don't think it is a very important thing. But to my mind, it's a very, very important thing if you're doing vestibular surgery. It cannot make a bad surgeon good surgeon, but makes a good surgeon a better surgeon. The preservation is better, the quality of function is better, and I think this should be the standard of care. In countries like mine, or in many other Asian countries or African countries where the things fail and we don't have the support, it's better to have multiple possibilities. So one system fails, you can use the other system. And this is the critical instrument in my practice, the calibrated suction, different sizes, which is used both for decompression and dissection of the tumor. This is again from Fukushima. This is what we advise: very wide drilling, 180 degrees, so that you have space. We do not drill more than 6 to 7 millimeter to preserve the hearing if we are attempting to do that. IAC drilling, again, there has been some groups which feel that IAC drilling worsens the patient's function. I don't agree with that. It helps in total excision and reduces recurrence because the tumor origin is inside the intracanalicular canal and the blood supply maximum there from ascending pharyngeal. This should be the standard of care. As I said, I emphasize the wide drilling, a lot of irrigation so that there is no injury to the nerves because of heat. Calibrated drilling if you want to preserve hearing, and use of endoscope assistance to take the lateral part of the tumor. Some adjuncts of techniques which we have found useful is the use of sodium fluorescein. When you inject sodium fluorescein, the tumor enhances, the nerve does not enhance, and that can differentiate the tumor from the nerve, because in giant and large tumors, everything looks like a nerve. The other thing we found is useful in large and giant tumors to see the displacement of the facial nerve before surgery. So we are more careful at that time, and you can see that that's this facial nerve. We could not identify the cochlear nerve consistently, but almost 80 to 88% patients we could identify the facial nerve. Now, I already said that if you're seeing the air cells, make an effort to see that you don't have air cells. If you have air cells, the large air cells, we put a little bit of fat. If there's small air cells inside the intraocular canal, like you see it there, then we just bone wax. But if it's a large air cell, we put first fat inside and then bone wax. And sometimes it may not be seen on a microscopic view. We use endoscope to make sure that you do not miss the air cell there. Now, another thing, when you have large tumor and you have an anatomical disturbance like ICA going into the intraocular canal, one has to be careful and release the the ICA from the intraocular canal before you can start decompressing. It's a little difficult, especially large and giant tumors, but critical that you save ICA, otherwise you can have a disaster. You can see the ICA going and reaching the intraocular meatus there. Sometimes it is inside the intraocular canal. In this particular case, it just stuck to the dura, the intraocular meatus. So we had to cut it off the dura, release the dura along with the intraocular ICA from the intraocular meatus, and then go on with the surgery as before. It's critical that you identify that and they preserve that vessel. Now, bleeding is another concern in large and giant tumors. Now, we have a teaching department, we have a residency training center, and most craniotomies are done by the resident. And so we injure the sinus, not uncommon. Now, I'll show you what is to be done. You almost hardly ever, I need to suture the sinus. It's very, very easily controlled. This is a large cystic solid tumor, and the craniotomy, I just want to go to the craniotomy site when I'm called. Retrosigmoid craniotomy. Now, this is when I'm called. There is an injury. I said, okay, put some gel foam, put some pack, and then I join in. And then it's very, very easy. 2 layers of gel foam, glue, leave it there. Put a patty over it, go back somewhere else and start operating. And then we do not, almost very, very rarely, that we have to suture or do some additional procedure to control, unless, of course, the sinus is completely severed. And the trick is not to push gel foam inside the sinus, so the sinus patency is intact. Now, when you're drilling the intraocular canal, sometimes this high jugular bulb, one can have problem. This is me doing it. And in spite of all the experience we have, sometimes we do injure the jugular bulb, as you'll see here. Now, this is jugular bulb drilling. Now, it's much more dangerous when you're doing in semi-sitting position because air gets sucked in under low pressure. When it is in a lateral position, it's not that much of a problem. But when there is bleeding, gush of bleeding, you just put something there to control it. And then we prepare a construct, which is a gel foam with a little bit of glue. And we partially push that gel foam. This is the first construct, first big gel foam, which will be removed. And then we prepare that construct and we put partially inside the jugular bulb with the glue inside the touching that bulb, and leave that, and leave another gel foam and leave for some time, go back somewhere else, and then come back, and you can still drill because you can't put a patty and drill it. That's critical that no patty is there when you are drilling it. So we come back and then you can still drill it and do the total excision. Now, when there is a bleeding towards the through the brain stem and the large and giant tumors, the veins are all compromised, veins are compressed, and when you're decompressing the tumor, there is a very high risk of injury to the veins and the bleed. Again, the trick is not to coagulate the veins. Again, this pressure, this is the bleeding on the brainstem side, and these are different tumors, which are different patients, which I've put it together to see. And then again, same gel foam, glue, patty, come back, go somewhere else, and control, and you can have the complete excision. Now, post-operative, now this is a patient who had this tumor, who had a blade. This tumor already, there was blood there, which is not so rare. We have seen large and giant tumors bleeding. And we operated it. This was a post-op immediate CT. The patient was okay, but there was a lot of blood in the subarachnoid space. We didn't take too much of notice to that. He was discharged, okay, and then came back on the 9th post-operative day with a hemiparesis, left hemiparesis. There was the diffusion restriction on the MRI. This is something which was not so well recognized. This was vasospasm, like a aneurysmal subarachnoid hemorrhage, because the blood in the subarachnoid hemorrhage. And this improved, fortunately, over a 2-month period. And this was a small case lesion in general neurosurgery. The recognition of the fact that delayed symptomatic cerebral vasospasm can happen if you have a lot of blood in the subarachnoid system. Now, what about small tumors left on the after a tumor excision like this? Immediate MRI, post-op, 3 months MRI shows some enhancement. Most of these are post-op changes and disappears, and men never need any adjunct treatment. This is some example. This is all with patient's permission. This is a 20-year follow-up. The tumor immediate post-op, this part, and this is 20-year, no adjunct treatment. So then no need to rush and do some adjunct radiosurgery. In many of these patients, they do not need it. Another patient, sometime this is 3 months post-op, you can see, which reduces at 1 year, again, no adjunct treatment. So just to emphasize, when you see enhancement in the post-op MRI, it's not always tumor, and sometimes there may be tumor which does not grow, so we do not need adjunct treatment in this kind of cases. What about hearing which is preserved? Now, this is a patient, 12-year follow-up. Now, hearing once in microsurgery, the advantage is if you have hearing preserved, it remains for good, unlike in radiosurgery. Now, the major, of course, the concern, the controversy, the debate is about small and medium-sized tumor to do what? Whether observe intracanalicular tumor, gamma knife, or microsurgery. Now, the tremendous, I think this is the greatest advances in neurosurgery. One of the greatest advances is by Lars Lexell, the gamma knife radiosurgery. There's no question in my mind. This is a good thing. And many of these patients we do not treat now is because we realize but many of patients do not need treatment. Many intracanalicular tumor, which were all treated before the gamma knife, we don't treat it now because we realize that gamma knife, most of them do not need it because they don't do anything. And we started following up. And this group in 2000, Walsh et al. And Sarabi et al. Talked about observation as a method of following these patients. Now, obviously, the problem is when you are taking the tumor out, as I said, the hearing preservation is not predictable, at least in my hands, and this is you can have a good face, but the hearing drops, which is not the case in radiosurgery. at least not immediately, maybe fewer down the line. So that's a big, big difference. And also when they lose hearing in radiosurgery, it's a very slow drop of hearing as opposed to microsurgery hearing loss, which is sudden, which patient realizes and is discomforted with that. In radiosurgery, they don't even notice that they have. So gamma knife is a good modality. And these are some of the literature. This is one of the first groups talked about the observations, and only 1/3 patients grow. So about 1/3 patients never needed any treatment. And there are multiple literature on that. Then the Pittsburgh group, they were the leaders of advocating radiosurgery and saying that the very high rate of radiosurgery control of the tumor in 90-95% with good hearing preservation. And they came out with multiple publications. You do early treatment when the hearing is normal, there's a very good chance that good hearing will stay for a long time. And this is in JAMA 2023. This is a prospective series, and the follow-up was very good. And they recommend that the small tumors and medium tumors should go for radiosurgery and not wait, because wait and watch, the 42% failed and had to go for radiosurgery. What I need to emphasize, in the small and intracanalicular tumor in this group, out of 100, 56 patients never needed treatment. So you're over treating if you're going to treat all that. That's my way of thinking. So we, in my practice, do not upfront do any treatment for intracanalicular tumors unless there's severe vestibular dysfunction. We have a period of observation to see growth or hearing drop before we advise treatment. So there are many studies which have come out very recently, the advantages and disadvantages, advantages of radiosurgery, advantages of observation, the conflicting data. So I will just go on through this. People who are interested can go to the literature and see it. But suffice to say that both observation and radiosurgery are appropriate protocols in patients who have small tumors, and you need to decide which one is what. I'll tell you what we do. Now, there is, as I said, there's a conflicting data, and this publication in, I think it's 2024, says that observation was better than upfront radiosurgery, other than in contrast to the other studies which I showed. Now, one of the first group to talk about good preservation of the hearing in intracanalicular tumor and advocating surgery is the Japanese group. This result has never been duplicated. The best results by far till date, I think. And this is Kuldwell group from United States. They do middle fossa approach, and they had very good preservation of the hearing preservation of 78%. But important to realize that 22% of serviceable hearing patients went to non-serviceable. These are mostly intracanalicular tumor, and 38.8% patients of normal hearing deteriorated. 7% had a facial dysfunction. So that's a concern for me. But the radiosurgery group have just come out saying that even CUSA-4 tumor, the first line of management could be radiosurgery, which I'm not a big fan of that. Because gamma knife does fail. This is one of my patients, 70-year-old lady with multiple comorbidities, 2.5 centimeter, and this appropriate indication failed, significant edema, symptomatic. We operated, and the trick of when we are operating, they can be operated, a little more difficult, but the trick of saving the function is to leave thin sliver of tumor attached to the critical structure and leave it, and you can still have a good facial function. So we published that, the first series, when we published it was, I think, 2020. And then subsequently within ACTA, we did it, I think, 3 years back, emphasizing the cystic recurrence following radiosurgery. There is also the concern of malignant transformation following radiosurgery. Very unusual. It's about 1 in 10,000 and more common in patients who are genetically predetermined, like the neurofibromatosis group of patients. There's a little higher, 1 in 1,000. We have been having 30 years radiosurgery. We have one case. This was my case where he was operated, had a small residual which recurred. We did gamma knife, and this patient had a proved malignancy from a benign tumor. So one has to be aware of that. For a young patient, so we are concerned about this before we advise gamma knife. There is a concept now which is being popular and which has been propagated is upfront elective subtotal excision of tumor and then followed by radiosurgery in all cases. I'm not a big fan of that. In my practice, as I showed, 19% of my patients, so 15 to 20% only need that. So there is always a period of observation is appropriate. And we do not go with an idea, with an aim for subtotal excision. We go for excising tumor, but we do not hesitate to leave tumor if the function is at risk. And if you have to do the radiosurgery, it's always elective, except patients who have high risk of recurrence. It's a giant tumors. Tumors with a multicystic tumor, they have a higher risk of recurrence. Or the patient, their follow-up is suspect, long distance, another country, we would probably go for upfront radiosurgery. Otherwise, it is always on growth. Now, how do they compare? Hearing preservation, almost similar. Microsurgery, less. Same in radiosurgery and observation across many studies, many publications. As I said, there is malignancy risk is there. One has to be aware and has to be discussed with the patient, especially in a young patient or patient who is genetically predetermined like a neurofibromatosis. The other minus is radiosurgery. We need to follow up in countries like mine and countries in Asia where the patients have to travel long distances for treatment. Follow-up is suspect. And then the patient come back with a large recurrence. So we have to be aware of that. Microsurgery, there's a little higher risk of facial dysfunction and other complication of surgery or anesthesia, which is not there in radiosurgery. And the risk of sudden loss of hearing. When you lose the hearing in a patient, suddenly the patient does notice and there is discomfort, as opposed to in radiosurgery, when there is a slow loss, they don't even realize that. Observation, 1/3 patients fail and there is gradual loss of hearing. So in my practice, intracanalicular tumor, as I said, always goes for a period of observation, especially if asymptomatic. Symptomatic, significant vestibular dysfunction, only they go to this part of the chart. Otherwise, if they grow or there is a hearing drop, then only they go for treatment. Now, symptomatic patients who have deaf, there's not nothing, these are intracanal, they're very small, CUSA. We do not think there is anything great we're doing, so we go for radiosurgery. If the patient has good hearing and the patient has intracanalicular tumor and is very symptomatic, either we would observe or go for microsurgery, because we think in intracanalicular tumor, we can still preserve good function. The tumor is extracanalicular but small, symptomatic, young patient, we advise microsurgery. Elderly or a lot of premorbidity, radiosurgery. Asymptomatic patients who are small tumors always goes for a period of observation. Many of these patients may not need any treatment in their lifetime. Young patients, good. This is a very controversial thing. Have changed. About 7-10 years back, I would go for microsurgery. But when we analyzed our patients, the hearing preservation in less than 2 centimeter tumor, outside canaliculi tumor, intracanalicular, not intracanalicular, the hearing is better preserved in gamma knife. So we moved on. Even in young patients, we would advise if their critical hearing is critical, for example, in a pilot and musician, we would not hesitate to advise gamma knife. If they're deaf, then it's a radiosurgery. Now, large tumor, CUS3, 2 to 3 centimeter tumor, symptomatic, young patient, microsurgery. Elderly, premorbidity, less than 3 centimeter, radiosurgery. Asymptomatic, again, observation. Young patient, normal hearing, microsurgery, compromise, micro, subtotal excision, and then we observe. Deaf, microsurgery, total excision. Giant tumors, calibrated structure, very, very critical that we are analyzing, we are monitoring, and we do not hesitate to leave thin sliver of tumor. We follow that up. If they grow, we go for radiosurgery. We do not do upfront radiosurgery in most of the cases. As I said, residual tumor, a period of observation only on growth, or giant multicystic tumor, we give upfront gamma knife. But this is a very difficult task, because the function, the last bits of tumor, when you are taking it out, and then that is the time when you lose the face function. So very, very important to decide when to come out. I think the facial function is critical in large and giant tumors. Hearing is occasional bonus. In handful of cases, we have managed to preserve it. And when it is preserved, it's not useful. Total excision, subtotal excision, both is okay with function preservation. I think today it is not appropriate to achieve total excision with functional compromise. It's a very difficult balancing act, and it's important we do not follow blindly. It is something which one can do. Literature doesn't help it. because do what is best for the patient and do what you can. It's not necessary to quote any XYZ because it's not medicine. It is hands-on thing. Not what we wish, but what you can. After all, his brain. Thank you very much for your attention.
Thank you, Professor Misra, for the very nice presentation, and it was such a work in short time for your
You
ample
muted, Dr.
experience.
Getcho. I think you are muted. I can't hear you.
How about now?
We
Hello?
can hear him.
How about now? Hello?
Yeah, we
Yes.
can hear you.
Okay.
Now.
Oh,
ahead.
good. Thank you, Professor Misra, for a very nice presentation. It was quite a journey of experience in this very short time, put all together in a nice way, and it's an honor to have this presentation. Now the floor is open for question and answer and discussions.
We have a question Q&A box if anyone would like to put in. We had one comment from Harshad, and he just wanted to say excellent presentation, lots of pearls of wisdom. You give all for that. Thank you. So if anyone else would like to make comments or have any questions, maybe Dr. Getachew, we could let you kick it off with one of your own questions, and then we can kind of go from there.
Yeah, it was a very nice presentation and eye-opening, I would say. The shift from the usual conventional surgery to gamma knife radiosurgery has been there, and thank you for that insight. My question is what are the predictors for the hearing preservation in the intraoperative time, specifically that we can follow other than the preoperative and then the decision making on top of that? What intraoperative measures can we pay focus into in order to preserve hearing?
Well, thank you. Thank you, Dr. Getcha. See, the critical thing is the patient's preoperative hearing. Now, if you cannot have the BERA monitoring during operation, then it's a by chance. If you preserve hearing, it's by chance because you have no knowledge about what's the status. So first, you have to be able to, have the waves 1 and 3 and the BERA intra-op. So the patient has, many times the patient says that I can hear, I can take telephones, but when you do the BERA, the wave 1 is absent and 1, 3 and absent, so you can't monitor it. So that's by chance. The tricks, what I have found useful is, number one, is very careful of using the bipolar near the nerves. Don't use the bipolar. A lot of irrigation when you're drilling the intra-aortic. The hearing nerve is a very, very sensitive nerve. So both heat and, from the bipolar, from the drilling can damage it, even if you preserve anatomically. A lot of irrigations, it doesn't get dried up. And when you are dissecting the nerve, even in a small tumor or a medium-sized tumor, the dissection should be side by side. It's not from lateral to medial or medial to lateral. We have lost electricity here. Can you hear me?
Yes.
Yes, sir.
Okay.
Yes.
Okay. So UPS is kicked in. Right. Good. So the side to side dissection is critical. Don't pull from lateral to medial or medial to lateral. That way you damage the nerve fibers. It's always a side to side dissection or up and down dissection rather than, this is something which is emphasized by Professor Yasser Gil in one of the talks. I don't know whether he has written it, but I heard one of his talks and his presentation, and this is something I think is a very, very important trick, which I got it from Yasser Gil, one of his talks. The other thing is, do not hesitate to leave tumor at the just medial to the intra-aortic canal, the meatus. That is the point which is maximum adherence of the tumor to the nerves. So leaving a couple of millimeter tumor there doesn't harm the patient. Many times they do not grow because the vascularity is taken off, because the vascularity is usually in the intra-aortic canal. These are some of the things which does help. But as I said, even after 1,000 cases, I can never say the patient that I will preserve hearing. So I always tell them that your facial function, we would be 90 to 95%, I'll be able to preserve. In large tumors, I say the hearing will not be preserved, but if it gets preserved, it's a bonus. So don't expect. So you have to, kind of counsel the patient before the surgery so that he doesn't get disappointed. And he knows that you're going to lose the hearing. And when you preserve hearing at non-functional level, it doesn't help the patient. It's like a noise because one side ear is good, the other side is very bad hearing. So that's like actually a noise. It's not bad, it's not good, it's actually bad for the patient.
Thank you, Professor. We have a question in the chat box. It says which is by Rupesh Singh. If I spell it right, I don't know. For tumor greater than 4 centimeter with tumor consistency which is firm or fibrous, how do we approach such tumor? It says.
He's talking about the fibrous tumors, which are
fibrous.
Yeah. So
inside above 4 centimeter.
Sorry, say that again. What is that?
And the size specifically above 4 centimeter, it says.
Oh, yeah. These are difficult tumors. These are very, very difficult tumors. And there we are mainly focusing on the preservation on the face. And it's actually much more difficult when the tumor is very vascular because you lose the planes. And sometimes a tough tumor is not very difficult because the plane between the tumor and the arachnoid is very good, right? And the key to, if you want to preserve function in a tumor which is giant, like 4 centimeter plus is something which is called giant, defined a giant tumor is 4 centimeter plus, which in your country, my country, is not uncommon. I think over a period of time, as I said, in my 100 cases, we had a total excision rate of 93%, right? But my total excision rate today has come down to about 78 to 80%. I don't mind that because I have an adjunct. I can always follow up, and if that grows, I can do radiosurgery. Because you damage the face, the patient will never, kind of happy about it. He will accept it, she will accept it, but she is never happy, right? So in a firm tumor, when you have a little more pull there and there is a higher risk, so you have to be careful that leaving tumor attached with strictly adherent to the nerves, leave it there. That's the way to go. I think Dr. Rock has a comment or question.
Yes, I have a couple here. Do you know the company that makes the calibrated sucker that you use?
It's an American company, actually. I don't know. What I'll do is, it doesn't look nice to tell the company name here. I will email you. Is that okay?
Yes, that'd be fine. Fine. Okay,
It's
I have another
company.
question.
It's an American company.
The sequence, the MRI sequence that you use to see the location of the nerve, is this, it looked like diffusion tensor imaging on that.
That's right. That's right. Diffusion DTI, yes. And now, of course, this we studied this about maybe more than 10, 12 years back. The image quality has significantly improved. The CIS images are much better quality now. So they combine. I can't tell you the exact details of different types of things they do, but the first one we did the publication on the DTI, diffusion
I
tensor.
see. Okay.
And Bisrat, could you help, given the audience we're talking to today, could you give them some pearls about on the larger tumors when you make a decision to debulk and what tools you like to use to debulk? Obviously, with the smaller ones, you tend to keep it more complete so you can see the nerve, but the larger ones, getting that mass out of the way. When you make that decision, and what is your favorite tools for that?
Thank you, Professor Damsi. That's a very much. I brushed over that because of the time. That's an important, very important question. And the faster you decompress, the better it is, because the last part of the tumor is the most difficult part, where you want time to dissect out the tumor closer to the nerves. So we use, I don't know, I know your focus. I think you would like to say where countries where the resource limited, that's what probably your focus. But if you have a CUSA, it's a very good tool. I love it. But even if you don't have a CUSA, the trick, I think, is in large and giant tumors, which takes time. Don't waste your time on achieving hemostasis. Keep debulking, debulking. Use your suction, a large bore suction. Use dissector. There's an enucleator. Take out tumor as fast as you can. The debulking part, and then only go for dissection of the surrounding structures. If you have CUSA, it's a very good tool. If you do not have CUSA, you can still do it because CUSA fails in my country also.
Yes, yes. Very well put. Very, very well put. And so important for the trainees and the younger faculty to understand that devascularize, debulk, and then get the planes is the key. Excellent, excellent. And can you just extrapolate some of your pearls to the other schwannomas that they might see, especially the more common ones?
The other schwannomas?
Yes, in that region.
The next common probably schwannoma is the trigeminal schwannoma, which is the much less difficult, I would say, than vestibular schwannoma, because the vestibular schwannoma is much more difficult because the nerves, which the eighth nerve is I think the most sensitive nerve which I come across in my practice is the eighth nerve. Even you just touch it, sometimes they have a drop of hearing, even if they don't lose it. The facial nerve is more robust, but in the giant tumors, everything looks like a nerve. That's why we studied that fluorescent thing, which is a small trick to identify the tumor and the nerve. The tumor enhances, the nerve does not, which makes you feel sometimes, keep on monitoring, keep on trying to stimulate, find out which is the nerve. So that helps. In trigeminal schwannoma, that is not the problem. You are not at risk of damaging the eighth nerve. You are at risk of facial nerve sometimes, and especially if you're going a middle fossa approach like giant, dumbbell tumors, greater superficial nerve. If you put traction on that, you can get facial, but much less common. The patient does have a discomfort because of the sensory deficits, which is not so well, kind of emphasized in the literature. But the patients do have, even if they don't have a loss, they do complain that there is a facial, kind of dysesthesia or a paresthesia, which is something bothering. Of course, we have some medicines which does help. But that is something. Trigeminal schwannoma is the next common tumor, much less difficult than the vestibular schwannoma. You can take it out much faster. The way I do it, if it is a posterior fossa, predominantly posterior fossa, I do a retrosig approach. If it's a predominantly middle fossa approach, I do a middle fossa approach. Sometimes I take out the zygoma, otherwise subtemporal approach. And if it's not huge tumor, I do a lumbar drain for especially middle fossa approach because we do not want retraction of the temporal lobe. It's a lax brain. If it is a dumbbell tumor, if it is a large component in the middle fossa, I will go from middle fossa. If it's a larger component in the posterior fossa, I would go for retrosig approach, which both of the approaches I am very, very, I'm conversant with, so it doesn't bother me too much.
It's wonderful for them to understand that. And do you modify your incision or your bony opening as you work up and down the posterior fossa? You showed a very general craniotomy for this one.
You mean for vestibular schwannoma or for trigeminal? Which one you were talking about?
Well, and actually the lower cranial nerves as well,
Oh,
just
okay.
for them to
Lower,
understand how you would
Yeah.
modify.
Yeah, lower cranium is different, because we do a more of a far lateral approach. Sometimes if it is, depending on the tumor is coming out in the jugular foramen, then we modify it. We do an infralab approach sometimes, and sometimes we an extended approach if it is going outside. Sometimes the jugular foramen tumor goes down to the neck, so we do a combined cervical, middle fossa, and retrosig approach. So yes, they are again they're more dangerous tumors because that's not a cosmetic. That's a very, very kind of I would say very difficult time for the patients, especially the patient who has a lower cranial nerve tumor, schwannoma, and whose lower cranial nerve function is normal. It's a major, major decision-making process. In my practice today, I would not hesitate to leave tumor inside the jugular foramen if the patient's lower cranial nerve function is normal. You handle that area and the patient is very, very disabled, especially for first few weeks on a Ryle's tube, then sometimes a peg. And I heard once a talk by Dr. Brackman, if I remember correctly, the famous neurosurgeon I think the House Group, was he?
Correct.
Los
Brackman?
Angeles. House
With the
group
house
in
group in
Los
Los Angeles. Yes.
This was a CP angle symposium in Barcelona, which I was also presenting, and it was many, many years back. He said, if you have damage, if you take out the tumor from the jugular foramen, the patient will never have a hamburger in his life. This is something which stuck to me, and I would be very, very careful in taking out the tumor inside the jugular foramen if the patient's lower canal function is normal before operation. If the patient is already lost lower canal function, we go for total excision. Otherwise, today we leave tumor and we do not hesitate if it grows to give radiosurgery. They do very well for that.
Excellent. What you've shown the audience is that your acoustic neuromas have taught you a very, a workhorse operation, which can be modified, but carefully modified for similar but adjacent pathology. Thank you.
Thank you.
We have a few more questions from our audience. One is asking about name Darpin Tucker. How
Sorry?
much time the name of our participant is Darpin Tucker, it says, and then how much time should we wait while doing tumor debulking if we encounter sinus bleeding with drop in endothelial carbon dioxide in the meantime?
Yeah, the trick is just go away from there. Leave gel foam, glue, patty, go away from there and do something else and come back. 5 minutes, 10 minutes, that's it. Sinus, this is a venous pressure, is a very low pressure bleeding. It's not an arterial bleeding. Even an arterial bleeding is a different ball game completely. You need to take care of it, otherwise you'll have problem. Venous bleeding, almost everywhere in the brain, you can stop just with patty pressure, and you have now constructs which are artificial things are available. I don't use it. I just use gel foam, which is available anywhere in the world.
Thank you. Dr. Pawan Verma from Lucknow. At what stage should we consider drilling the intra-auditory canal? And what are the tips to remove the last part of tumor overficial nerve medial to the internal auditory canal?
Yeah, it's a very, very important question. Again, I think Professor Dempsey already emphasized that. First, debulk. You have enough space before you go to the intra-auditory canal. You don't try to dissect the normal structure, the nerves and the vessels. When the tumor is large, you will have problems. So we debulk enough space. We are not retracting the cerebellum. Majority of my cases, even in lateral position, I don't use the retractor, okay? But I don't hesitate. When I'm drilling, I put the retractor there so that my drill accidentally does not hit the cerebellum. So I use the retractor, but not for retraction, for supporting. So the answer to that question is debulk. We have a lot of space, and then you drill it. We drill the first with what I use in the practical thing. What I do is, I don't know, the names have changed, but it's the old M8 of a Midas Rex. This is the one I use, the burr. And then once I reach very close to the last parts of the bone, I change over to a diamond drill. Again, lot of irrigation. Number one, lot of irrigation. Number two, no patties in the field. No patties in the field anywhere when you're drilling. One patty gets in the drill, whole brain gets screwed completely. You can lose the patient. So remember, for the young neurosurgeon there, do not leave a patty when you're drilling. Number three, is better to support the brain with a retractor even if you're not retracting when you're drilling, because sometimes the drills jump and it can hit a normal structure. So it's a good practice. And the next thing, when you are doing that, again, we can decompress especially tumors which are large extension to the intra-auditory canal, and large tumors inside. We can decompress inside the intra-auditory canal with a very low CUSA, okay, very low strength CUSA, and decompress so that you have space again. And then you decompress. After decompression, you dissect the tumor from side to side. I think I showed it that you use a stimulator dissector. So this is giving you a feedback all the time when you are close to the very low current, okay? The 0.02 we put it, 0.02 in my nerve stimulator, the NIM stimulator, we use it. So that is 0.02, and so it doesn't damage the nerve, but the moment it reaches, it gets a bip, right? So you are away from it. So the last parts of things, once you have decompressed, we dissect with a stimulator dissector from side to side and take the last parts of the tumor with endoscope assistance. We will try to preserve hearing. If the hearing is not a concern, then you can be more generous in your drilling.
Thank you. Two more questions, and then I think we can wrap up. One is the tricks about arachnoid dissection on the dorsal surface of the tumor.
The trick of the arachnoid dissection?
On
Right.
the, yeah.
Yeah. So there is, again, there is something which has been a lot of discussion about whether that's an arachnoid or that's part of the nerve and so on. There's a Japanese group which think there is no arachnoid over there. That is, the tumor is intra-arachnoid. But I don't really kind of worry about that. What I worry is everything which is vascular, vessels, large vessels, they're all normal vessels. And the shining membrane, whatever it is, take the shining membrane out of the posterior surface of the tumor. Now, if you have a doubt whether this is tumor or this is arachnoid, sometimes the large tumor is very difficult because everything looks like, tumor. So err on the side of the tumor, right? You understand what I'm saying?
Yeah.
Err on the side of the tumor. Take a little bit of tumor along with that shining membrane. What I think is the arachnoid, that's a shining membrane. I take a little bit of tumor. If I'm losing the plane, I take a little bit of tumor along with that plane, along with that transparent membrane. And then I come back later on to be in the precise plane. All right. And that makes it safer. If I err on the side of membrane, then I may lose it. And then now I may go to a normal structure, the nerves, the vessels, and so on. So the trick is, and again, I would try to emphasize the posterior surface. A lot of people keep stimulating the posterior surface. In 1,000 cases, I have not seen the facial nerve in our MR imaging, not in my practice, the facial nerve displaced posteriorly, though it has been reported. But Professor Sami, who has more than 7,000 maybe now, but in 5,000 cases, he commented that he had never seen a facial nerve disposed completely posteriorly. So don't worry about the posterior surface. Peel out that transparent membrane from the tumor. If you are not sure, take a little bit of tumor along with it and come back later. Every blood vessel which is big is a normal vessel. Think it is a normal vessel. It may be tumor vessels. You trace it with the tumor and then interrupt it.
Thank you, Professor. And how about the CUSA settings? Rupesh Singh would want to know about the change in the CUSA settings while decomposing the tumor. What are the common settings used by you?
Well, I think the different CUSA companies are there, so I mean I can't tell you. But what I do is, when I'm doing in the middle of the tumor, I'm at a little higher CUSA. Again, depends on what sort of tumor it is. If it is a fibrous tumor, you need a little more strength. If it is a soft tumor, you go down on 30s. I mean, this between 10 to 100. Most of the time I work at around 30, 40, right? If it is a very fibrous tumor, at 50 to 70. Inside the intracanalicular canal, it's around 20, 30. Does it help?
Thank you.
Yes, sir.
Thank you.
Okay.
I think we will close at this time. I want to add my great thanks. Dr. Professor Misra, this is outstanding, and the lessons learned go far beyond this particular type of tumor to all of microneurosurgery about the handling of tissue, hemostasis, debulking. Outstanding, just as what this audience needs to hear. We can't thank you enough. Thank you.
Thank you. Thank you, Professor Dempsey. Thank you, Professor.
Thank you.
Thank you, Getjo, and thank you for asking me to contribute. It's a pleasure and honor to be here.
It is our honor. And for everyone from FIENS, we wish you a very, very happy and healthy weekend. Thank you.
Thank you very much.
Thank
Bye-bye.
you all.
Take care.
Bye-bye.